Hi, everyone. Good evening. Welcome to our webinar tonight, where we'll discuss care management for the Step 2 CK, shelf exams, and Step 3. My name is Mike Stevens. I am a PGY3 dermatology resident, and I have been with med school tutors for over 4 years now. I am thrilled to be joined tonight by an incredible co-host, Dr. Morris, and I'll give her a second to introduce herself.
Hi, everybody. I'm Callie. I am a second year pediatric resident. I have been with med school tutors for almost a year now and love tutoring for all of the step exams, particularly step 2 CK and step 3. So I'm really excited to talk to you guys about this topic tonight.
And then just to give you guys a little bit of a background, so this webinar is of course brought to you by Blueprint. And so just so you have an idea of who we are, and we'll discuss this a little bit at the end as well. But really the entire mission of Blueprint Medical Prep is to support you, as the banner at the top states, kind of all the way through the medical journey from the beginning of med school through to residency and even beyond that into board exams. The kind of facets of that include the Cram Fighter study plan that kind of helped to create a study plan, a calendar to help you approach these tests, med school tutoring, which is the one-on-one tutoring that we do, residency consulting if you're getting ready to apply for residency, as well as QBanks, including Roche review. And so without any further ado, we can kind of dive into what we're going to talk about tonight. I think just to state up front, a couple of logistical things. You might see that there's a comment in the chat. That's really the best way to reach us. If you have questions over the course of the webinar, we'll do our best to answer them in real time just by replying to your messages. Sometimes some of them might be a little bit more than we can type out, and it's easier for us to kind of state. And so we'll also have a live Q&A at the end, which is honestly my favorite part of the webinar, to be able to address all of the things that we don't get to during the course of the evening, and any questions that we weren't able to answer in real time. And so diving into it, kind of our plan for the evening is basically giving you a general idea of the pathway, how you approach management of patients, and in particular with an idea of how you approach management of patients in step 2 and step 3 vignettes. With an emphasis on triage and acuity, so identifying how severe something is and how quickly it needs to be intervened upon. In all of medicine, there's a movement towards evidence-based practice in diagnosing conditions and managing them. And just to state it up front, because this is going to be a running theme through the night, recognizing that, oftentimes we want to do something, but, frequently doing nothing and just observing is often the appropriate next step in management. That folding into the next point here, that favorite question that everyone has, what is the next best step in management? It's an all too common one that you're almost guaranteed to come across very frequently on step 2 and step 3. And so we want to make sure that you have a systematic way of approaching that and thinking through these kinds of concepts. And then I think the majority of the webinar tonight will actually be based on, we'll run through some USMLE-style questions that kind of highlight that next best step in management. And then again, as I mentioned before, we'll wrap up with that live Q&A. So make sure to stick with us all the way through and hang in through that live Q&A if you have any questions there at the end. All right, so I will turn it over to Dr. Morris and give us the approach to the undifferentiated patient.
Yeah, so thank you for the kind of great intro and kind of setup for what we're going to be talking about tonight. I think big picture, approaching these questions on your step 2 or your step 3 can be really challenging, particularly the ones that say, what is the next best step? Because those are the ones that, there might be numerous answers that in theory could be right, but you have to pick out which one is actually the next best thing to do, not just all of the things you possibly could do. So in general, on these exams, knowing the treatment for a thing is easy if you know what the diagnosis is. So most pathologies that you'll see, for example, hypertension, have numerous options of what could be your next best treatment option. So whether that's an ACE inhibitor or a calcium channel blocker or a thiazide diuretic. However, on the kind of opposite side, most medications kind of have a single major indication for them and then a couple minor indications. So a great example of that is metformin. You know, we think about that as, you know, our kind of primary go-to drug for type 2 diabetes, but then it can also be used in situations like PCOS, which is a little bit more of a minor indication. You know, usually your go-to for PCOS is going to be oral contraceptives, but if they also have some insulin resistance, you can, you know, throw in metformin and that might be a great option. However, diagnosing things is a little bit more difficult than knowing these treatment options. And that's where the bulk of what we're going to focus on tonight is how to decide what diagnostic tests you need to do, or what you really need to do in terms of working up and managing these patients as the next best option. So we'll talk more in detail later about screening versus diagnostic tests. But I think, you know, a classic example that we think about is that, you know, like a D-dimer is a great example of this. So if they ask you, if you are convinced from the vignette that somebody has a PE and they ask you what's the next best test, a lot of people get tripped up because they will put a D-dimer on there and they will also put like a CTPA or CT angiogram, whatever it is listed as on that question. And both in theory can be good answers. But if you are sure that it is a PE, you want to already jump straight to the CT versus a D-dimer is more of a screening test that can help rule out a PE for you. So that's a classic example. We'll talk more about those types of tests and how to distinguish between those later. But that's just something to kind of keep in mind. And then the other thing that comes up very, very frequently is what is the best diagnostic study for whatever the condition is. I will give a big spoiler alert that if there's an option for ultrasound on your list of options, usually that's a great choice for most things. Obviously, you know, there's exceptions like a stroke, you would want to get a head CT, not a head ultrasound, things like that. But if it's an ultrasoundable organ, that's usually a great approach in kind of picking the most low cost, low radiation, easy feasibility exam is going to be your best next step. So for example, something that would be incorrect would be a CT urogram that again could show you if there's, you know, a urinary obstruction, but a renal ultrasound would be a lot easier and would be your first line test. So those are just some kind of basic things to keep in mind as we talk some more tonight about these different types of questions and really just kind of some big picture frameworks to think about in terms of diagnosing and then managing these conditions.
Awesome. And that's a perfect segue kind of into this next point about thinking through screening and diagnostic tests. And so if you have a patient in front of you and you don't know if they have a condition or not, and you want to screen them for it, the entire purpose of screening is you want to be able to capture, you know, every possible person that has the condition. And you don't want people to, quote unquote, slip through the cracks that have it that you aren't detecting. And so what that means is sensitivity. You want a test that has very high sensitivity. But as is kind of an age-old problem in these diagnostic tests and these screening tests, when you have high sensitivity, you often have to sacrifice some of your specificity. And so, you know, if that's the case, then oftentimes you'll see in these questions, you'll have like a two-step process for diagnosing a condition. I think lupus is a great example. You know, you can screen with an ANA and see if that's positive. But many people have an ANA that's positive without necessarily having lupus. You can follow it up by a confirmatory test like looking for double-stranded DNA antibodies, which are very specific for lupus, but not necessarily that sensitive. And so that's kind of one good point just in general when you're thinking about screening tests. If you're definitively trying to diagnose something, that does lend itself with more kind of disadvantages almost. It might be a more invasive kind of procedure. It might involve more radiation. And it might also be those as well as more expensive. And so these are just some examples of, you know, different diagnostic tests that can be done in working up a condition and trying to diagnose it. And so, you know, I think Callie did a great job. I already brought up the concept of a D-dimer, and that kind of folds into this last point down here of a CTA or a CTA chest or a CTPE. So if you have kind of if you're unsure if a patient has PE or not, And they maybe do, or they maybe don't, but you don't necessarily want to jump all the way to the definitive diagnostic test. You can start with the D-dimer. And that can almost be like your screening test that's sensitive for PE, but very nonspecific. It's, just because you have a D-dimer doesn't mean you have a PE. And when that's positive, if it's positive, you can then move on to get the CTA as kind of confirmation of that. But noting that it's going to be more radiation, a more of an expensive test, and it requires injection of contrast in a way then can be considered more invasive. Similarly, breast mammography is a screening test that is a little bit more straightforward in terms of imaging than trying to biopsy a mass that might be more invasive, but it does involve radiation in a way that ultrasound doesn't. So it's a consideration across the board, across all of these different examples of balancing what your pretest probability is for a condition and how much the test is going to help you change from your pretest probability to your post-test probability. I want to highlight what was said before about ultrasound. If you are completely stumped and you don't know exactly which is the best modality to use, if ultrasound could diagnose the condition that you're worried about, it's probably going to be your starting point. Appendicitis, hepatobiliary diseases, renal ultrasounds, it's very straightforward to obtain. It doesn't require any radiation. It's not at all invasive. It's a very straightforward kind of diagnostic test. And so that's definitely to go for, especially if your patient is pregnant, just to highlight that, because again, it comes with very much fewer risks than other tests. So then to the next point, how do we systematically think about choosing the best test?
We kind of touched on this already, kind of big picture. If you are stuck on a question and you are like, oh, I could maybe get an ultrasound, or maybe I could get a CT, or even like I could get a CT or I could get an MRI. Big picture is think about what is the cheapest test. So think cheap and easily available. So the most common things for those would be your ultrasound and your like x-rays. Those are pretty cheap, commonly available at most, emergency departments, urgent cares, even, primary care offices. The other thing to think about is radiation, particularly we brought up in pregnant patients. That's a big consideration. In my world in pediatrics, we also think about that, trying to expose kids to as least amount of radiation as possible. So if you have an option to do something that doesn't require radiation, you might want to consider that over, doing a CT scan that has radiation. I will say where this becomes a little tricky is if you have like a CT and an MRI, and that kind of comes to the last point about invasiveness or kind of expense that goes along with it, or just the feasibility. So a head CT is really quick. You can get it done in 30 seconds in a trauma bay if you need to, versus like a brain MRI. Although an MRI doesn't have radiation, which is great, but it takes a little bit longer. So you have to kind of take this, within the context of whatever patient that you're given in the vignette, when it comes to the invasiveness and the radiation component. But in general, you can almost guarantee that starting with an ultrasound or an x-ray is a better option than a CT or an MRI if you have the capability to do those things. I would say, like I said earlier, the big exceptions would be, you want a head CT to rule out stroke. You don't wait on that. You just go ahead and jump to it. Same thing even with PE. If you are convinced that this patient has, just got back from a road trip, for 16 hours and is also on an oral contraceptive and now has chest pain and shortness of breath and is, satting in, the high 80s, you can go ahead and get the CT PA. You don't have to wait and get a D-dimer first, because if it's high, you're going to go ahead and get the chest CT anyway. So there's, specific examples where you can maybe jump to a little bit bigger test. But in general, try to pick the least invasive and the cheapest option. This little kind of clinical pearl we have down here about PET scans, hardly ever going to be the right answer on this exam, unless you have a patient that has like a known diagnosis of cancer and you are trying to look for metastases. But really on this exam, any of these exams, your shelf exams, step 2, step 3, it's hardly ever going to be the right answer. So even if you're concerned the patient might have cancer, you're going to look for the primary source of the cancer with either an X-ray or potentially a CT prior to jumping to a PET. So it's really not ever the right answer. So if you're really considering picking it, take a second and look at the other answer choices and see if there's something better before picking it.
Awesome. And so kind of folding them from there, that's the diagnostic realm of things, and starting to think a little bit more then about the therapeutic realm of things. Again, the key principle of this is triage, and I think that this is very applicable to what our emergency medicine colleagues do in terms of trying to figure out what is the number one problem that needs to be handled right now versus what can be deferred that we have more time to think about. And so, to a certain extent, you have to be able to do this in the vignettes as well. And so you have a kind of undifferentiated patient in front of you. You figured out what's going on, and now you need to get a sense of how quickly does a therapy need to be introduced. And so it pains me, but a lot of dermatologic conditions and many other, and a lot of other conditions, they don't necessarily come with a lot of morbidity or mortality in the coming seconds, minutes, hours. And so you have time to think through this and think about treatment. And so, for example, psoriasis, this is handled on an outpatient basis. You don't need to be in the emergency department unless it's like, involving your entire skin, and very fulminant. If you, and so you can think about treatments on a more weeks basis. Then you want to stratify into things that are more life-threatening over the span of days. So you don't have to jump right now, but the patient needs to be in the hospital. We need to be working on things to help stabilize them out over the next couple of days. And so a great example of that would be a heart failure exacerbation. Patients coming in short of breath and they're deoxygenated because they're backing up blood and fluid into their lungs. After that, kind of becoming more acute, life-threatening in hours, think about sepsis. Patients becoming hypotensive, they're not perfusing, they're having some end organ hypoperfusion. And then life-threatening in minutes, you think about cardiac tamponade or tension pneumothorax, or entities where you have high risk for cardiac arrest or are very serious complications over the span of seconds to minutes. And so once you have this kind of framework of how to triage these things, it's really a kind of a crucial clinical skill just to have in your overall practice. But it helps you get an idea of what you need to do next because you know how quickly you need to introduce that therapy. And so that kind of folds into this next point here.
So I was just going to say something. I think cardiac tamponade is a great example of just obviously something that's very acute that you need to take care of, but also a great example of a time where you don't necessarily need a diagnostic test before proceeding to a treatment. So I think that's something that is really hard to conceptualize as well. So sometimes you'll get a question and it's clearly describing somebody with cardiac tamponade. They have muffled heart sounds, they have JVD, they're hypotensive. And then it'll say, what is the next best step? So it doesn't say in diagnosis or in management, it just says what's the next best step. And one of the options might be get an echocardiogram, which in real life, honestly, if you're in the trauma bay, somebody might be like getting an ultrasound and looking for, fluid in the pericardium anyway. But the correct answer is you do a pericardiocentesis emergently. You don't need an ultrasound to tell you that there is fluid there. If they clinically are presenting like that, you treat them. Same thing with tension pneumo. You don't need a chest x-ray to diagnose a tension pneumo. You just put a needle in it. So those are great examples of things where sometimes they'll try to trick you by putting, again, the thing that if you had time would confirm the diagnosis, but if it is that diagnosis from your history and physical, you just go ahead and jump straight to the treatment. So that's kind of, talking about this kind of next slide are great other examples of that. So if you have something that's going to be life-threatening within hours to minutes, do those things first to save the patient versus trying to figure out exactly what's going on. So another example of that is an umbilical cord prolapse. So you don't wait to do other testing. You immediately will end up delivering that baby. Try to put the cord in place and then deliver the baby via emergency C-section to save the baby and the mom's life. In terms of like abnormal uterine bleeding in a postmenopausal woman, you can do other diagnostic things, but a lot of the time, if it's seems like abnormal bleeding and they're postmenopausal, the first thing on your differential is going to be endometrial cancer. And so you're going to go ahead and get an endometrial biopsy. But if they're, not hemorrhaging, if their vitals are stable, again, you can do that on an outpatient basis. It would be urgent, but not emergent. If you hear a systolic murmur at the cardiac apex in an asymptomatic young patient, again, there's a couple things that could be, depending on what their history was prior to that. But something you're going to worry about is could this be hypertrophic cardiomyopathy, which again can be life-threatening if this patient goes out and tries to run a marathon, and has, significant symptoms from that. So, you can get an echo, you have some time in this case, but still it's not, it's not one of those things that's super emergent and that you have to intervene right away. But you're going to want to get an echo quickly and then kind of, further advise the patient on things to do. Chest pain with EKG and ST segment elevations. Again, you can get a troponin. Obviously, you should get your other labs, but this is a patient that if they say, what's the next best step, it's going to be take them to the cath lab. So that's another one where, again, you can maybe order more diagnostic tests, but you might not need to. You might just send them to get the therapy that they need. And then last but not least, you're kind of penetrating abdominal trauma. So somebody with a stab wound or something like that to their abdomen, and they have a positive FAST exam. So they're the quick ultrasound that they do at bedside in the trauma bay. If they're hypotensive, there could be numerous things that might be your next best step. One of them might be place an IV and start giving them blood. Or if that's not an option, your next best step is take them to the OR because presumably they have internal bleeding that you need to go take care of. So again, you might want a CT scan to see exactly where it's coming from, but if they're hypotensive and bleeding, you need to give them blood and get them to an OR and do an exploratory laparotomy. So you really have to kind of think of the clinical context for all of these situations and really think about, what is emergent and what do I have to treat right now, or what can I kind of have a little bit more time to maybe get a couple diagnostic tests before, making a final diagnosis and suggesting a treatment. So really thinking about the vitals when you're looking at your vignettes, looking at the vitals of these patients, I think is crucial, because sometimes, things aren't as acute as they might seem based on their vitals. And so if their vitals are stable, you might have a little more time. Same thing goes for those of you studying for step 3 for the CCS cases. I think your vital signs on those cases are also really important to think about. If they are hypotensive and tachycardic and they're in the ER, you should probably be placing some orders, at least, place an IV, maybe put them on monitors, get a pulse ox, do all of that before you even do a physical exam on those patients. So just kind of keeping a close eye on people's vital signs and, the acuity of the situation will really help you decide what your best next step will be.
Awesome. So to kind of summarize all of this into a little bit of a framework, again, to Callie's point, the most important thing is thinking about the acuity of the illness and kind of triaging. And so when you are looking at a patient's vitals and getting concerned, or kind of looking at their clinical course and getting concerned, if you feel like what's happening is immediately life-threatening, then you want to go ahead and perform life-sustaining therapy, in the moment. So if it's a tension pneumothorax, as was mentioned, then you need to go ahead and do the needle decompression. If it's cardiac tamponade, you need to do the pericardiocentesis. And so, these are things that are bad and need to be handled quickly. If something's not immediately life-threatening, then you're in a little bit of a limbo of some questions are going to present it in a way where it's clearly intended to be a diagnosis question. You don't know what's going on exactly, and the question is intentionally written so, and you have to kind of order the best diagnostic test. So kind of like what was mentioned, if you have abnormal uterine bleeding in a postmenopausal woman, then you would want to consider, you don't know if it's endometrial cancer, but you're worried it could be. And so then you'd order the best diagnostic study of an endometrial biopsy. On the other hand, if the diagnosis is pretty clear and it's a clinical diagnosis to the point before, like psoriasis would fall under this umbrella. If you can make a clinical diagnosis of psoriasis and you know that that's what they have, you can go ahead and start them on treatment based on your clinical judgment. And then just to emphasize it again, it's going to be a running theme throughout the course of the evening. Remember, again, that it's okay to do nothing. If you find that you're in this camp over here where something's not immediately life-threatening, again, psoriasis, if someone has like a small patch, it doesn't really bother them, they're not itchy, they don't have any joint pains, it's okay to monitor that. You can put them on a topical steroid, or frankly, you could do nothing. And that's acceptable. And so just keep that in mind, because it's often going to be, they're going to try to lure you astray with, all of these different, often invasive, irradiating, expensive tests. And the reality is you could get away without having to do any of those. And so let's put this into practice. We'll do it. This is kind of the fun part of our webinar tonight, is we'll do a few practice questions with you guys.
All right, so I'm going to tackle this first one, and feel free in the chat if you want to start like typing what your answer is, or if you have any like questions or comments or like things that lead you to your answer, feel free to just kind of share those in the chat. I think it makes it more fun when it's a little interactive. So this is a 24-year-old woman that's coming into the emergency department with a 6-hour history of acute onset shortness of breath. So yesterday she returned home from a vacation after a 10-hour car ride. She takes an oral contraceptive daily. In the emergency department, she has an episode of syncope while walking to the bathroom. Her temperature is 37 degrees Celsius, blood pressure is 92/64, heart rate is 134, respiratory rate is 26, and oxygen saturation is 87 on room air. Physical exam reveals clear lungs and regular tachycardia. So which of the following is the next best step in management? So I feel like this is a very classic example of what this diagnosis is. If anybody wants to shout out in the chat what we think is going on here, I think you probably all know. And yeah, so most likely had a DVT that progressed to a PE, and I would go as far as to say that this is probably a massive PE. And the way that I can tell that is that her blood pressure is 92/64 and her heart rate is 134. Like, that's pretty impressive to have that degree of hypotension. So this isn't just the kind, because again, there's people that are walking around with PEs all the time, actually, that are small and they might not even know they have it. But in her case, she's kind of having acute hemodynamic instability. So the best next step in management in this case, our options are either getting a D-dimer, getting a chest x-ray, starting her on rivaroxaban or Xarelto, getting a CT of the chest with IV contrast, or initiating a heparin continuous infusion. And we've got a great a number of people kind of shouting out that in this case, the next best step is, you're totally right, we just start her on the heparin, because again, a lot of these things are right. Of course, are we going to eventually probably get a CT of her chest and with contrast and confirm that it's a PE? Sure. But in her case, and again, they didn't tell us this in the history, but assuming that she doesn't have some weird bleeding disorder where we're concerned about starting her on heparin, you're going to go ahead and start her on it. Because she is having hemodynamic instability, and so treating the PE is more important than 150% confirming it, especially when the story kind of checks out that it sounds like a PE. I think this is a great point. Some people were saying in the chat that D is really, really tempting, but again, it's easy to see that and say, oh, of course that's what I want to do, but it would delay her getting the treatment, having to give her contrast, giving time for that to get in her system and then get the scan, that would delay the treatment with heparin. So yeah, you just go ahead and treat her right away. And so kind of when we're thinking of our kind of framework that we talked about earlier about the acuity of an illness, obviously in this case, this was an imminently life-threatening, she is hypotensive, tachycardic. So we want to treat this right away. And so she would go into our kind of bucket of, perform the life-sustaining therapy immediately. And The other thing that I like to point out when we talk about PEs, sometimes they will even give you some other kind of treatment options for PEs. So like catheter directed thrombolysis, sometimes they'll throw in other kind of miscellaneous things like IVC filters and other things that sound like they could potentially be correct answers. And even if they might go on to need some of those treatments down the line, starting heparin from the get-go is the very, very, very first thing that you should do. And that is always the correct answer.
Awesome. That was amazing. So we'll keep it going. We have, I think, a total of 5 of these altogether. So this is our second one. And so to apply the same kind of strategy that we did in the last one, we'll do another example question. So starting off, the question itself, which of the following is the next best step in management? That's going to be a running theme of the night. You can anticipate that that's going to be what all 5 of them are. So again, we're dealing with a management question, and to the points that we brought up before, what is the diagnosis? Do we need to do a diagnostic test to figure it out? And how acute is what's going on? And that will help inform kind of what we're going to do now. So reading through the question, we have a 3-month-old infant brought to the clinic for a well child examination. And so, again, kind of taking inventory right off the bat, the child is brought in. To the parent's perspective, the child is fine, and they're just coming in for a regular checkup. And so there's not necessarily an acute problem. It's not a problem-based visit. He makes 6 wet diapers per day and cries for the bottle every 2 hours. He's at the 70th percentile for height, 70th percentile for weight, and appears well developed and well nourished. So all of these things seem pretty reassuring to me. His parents point out a periumbilical lesion that has been present and has even increased in size since birth, as shown in the photo, and which of the following is the next best step in management. And so looking through our answer choices, we have a combination of diagnostic tests as well as treatment options. And again, so when you're approaching a question like this, thinking back to our framework, how acute is this? Well, the child is pretty well. It's been there for a long time. There's nothing in this vignette that suggests to me that this might be a life-threatening kind of condition. So I would definitely say that we're in the not life-threatening realm of things. And then the next point is, do we need further diagnostic information, or do we feel like we have enough based on the clinical exam alone? And so again, I love that this audience participation is amazing. So if a couple of people are chiming in with what they think is going on, if other people want to kind of give a thought about what you think this might be, or what you would do to figure out what this might be. We'll give a couple of seconds for people to chime in. So we have some votes for hemangioma, and that's exactly right. So this is an infantile hemangioma. And so when you're thinking about management, so this is, again, in that kind of framework we have, we're in the clinical diagnosis realm. We can make this diagnosis without necessarily needing more diagnostic information. And so if you get to that point, you can rule out a lot of these diagnostic tests. We don't need to biopsy this lesion. It's a skin biopsy, so our organ is right there, but it's a 3-year-old. It requires shots and stitches, and if we can spare a 3-year-old having to go through all of that for what's likely a benign condition, probably better. MRI of the brain would happen in certain areas if you had. It's more specific in terms of different types of hemangiomas that probably outside the scope of what you need to know for these tests. Excisional biopsy of the lesion, same thing. We know what it is, and we can treat to that without necessarily having to excise it. So this is a good example of just observing, which is, you guys were great. A lot of people chimed in with D, and that's exactly right. Again, it's okay to do nothing. And in this case, a small lesion in an area that's not very cosmetically sensitive, that will go away on its own with time, is a perfectly reasonable next step in management. You don't necessarily have to treat these. So clobetasol cream is reasonable if you think there's an inflammatory process, but this isn't necessarily an inflammatory disease. And so we probably wouldn't see a lot of benefit with clobetasol. So again, just to put it back into this framework, not life-threatening. We know what it is. And so we're going to do the first line therapy or treatment, which includes just observation. All right, and so we'll move on to, you guys are doing excellent. Thank you again for participating. And we'll keep it going with a third question.
All right, so our next question, again, the sticking with the theme, this is going to be a what's the next best step in management question. So this is a 38-year-old who's coming into the emergency department after a high-speed motor vehicle accident. Once you get him into the trauma bay, he is alert but in visible distress. He's got a large bruise across the right chest and abdomen. His vital signs reveal a blood pressure of 82/58. His heart rate's 148. His respiratory rate is 36. His breath sounds are absent on the right side of his chest, and he also has JVD. So which of the following is the best next step in management? So first of all, what do we think is going on with this patient? What diagnosis is most likely in this scenario? And feel free to kind of shout it out in the chat as well. Got a couple different answers here. So great. Thank you guys all for participating. Feel free to keep chiming in if you're still thinking about it. So big picture, when I get a question like this, where, I mean, first of all, let's put it in the framework of, is this patient sick or not sick? Is this acute or not acute? And we can tell by looking at his vitals that this is a patient that we probably want to act pretty quickly, whatever we're doing, because he is hypotensive and tachycardic. So big picture, we want to do something pretty quickly. So we probably know that we might not want to do, some of these things like, a focused ultrasound assessment of the abdomen, because that's going to take more time and we might need to act a little bit quicker. And same thing with kind of chest x-ray. If we know what this diagnosis is, we might just need to act. So there was a couple of different comments in the chat, which prompts a great discussion about, what is going on here. The key word in this vignette is that his breath sounds are absent on the right side of the chest. If they would have said breath sounds are equal, but he had JVD and hypotension, you might be thinking this could be a cardiac tamponade like we talked about earlier. But with his breath sounds being absent on that side, that kind of leads you more towards the diagnosis of probably a pneumothorax. And more specifically, most likely a tension pneumothorax, given the fact that he's having hemodynamic instability. The other big thing that you might see that they didn't say in this vignette with a tension pneumothorax is they'll often tell you about the tracheal deviation. So if you have such severe collapse on, let's say, the right side of your chest, where you have, the entire right side of your chest is just full of air, your lung is collapsed and it's kind of compressing on your heart, compressing on your trachea, that's when you'll see that tracheal deviation as well. So yes, as everyone is saying in the chat, what do we do in this case? We do a needle thoracostomy. So you want to put a needle in this chest and get some of that air out. Sometimes you'll see a little bit of a discrepancy in terms of, it'll say needle decompression or chest tube. Most of the time you can start with needle decompression and then transition to a chest tube. So needle decompression will be right prior to doing a chest tube, but if your only answer is chest tube, that also will suffice. Some of these other answers might be things you're thinking about, like, do we need to intubate him and mechanically ventilate him? He's still breathing, he's awake, alert, so you probably don't need to do that right now, but you might want to prepare for that if he were to decompensate further. We don't need to start CPR at this moment. He has a pulse, again, is awake, alert, breathing. But again, those are all great things to kind of be thinking about in the background. But the big picture is we didn't need any further diagnostic testing to determine what the diagnosis was, and we needed to immediately fix it without doing anything else first. And so this is a chest x-ray showing a tension pneumo. So as you can see I forgot, I don't have control of the mouse. You can see the pneumothorax on the left side of the chest. So you can see kind of his lung is completely collapsed over there on that left side. And you can even see, if you look kind of up at the trachea is deviated a little bit to the right. This is an x-ray that as the Pearl says over here, should have never been taken, right? And of course, they probably did or maybe attempted a needle decompression prior to this. But you shouldn't need to get a chest x-ray. You'll get one afterwards to make sure that you were successful. But you should never have a x-ray of a tension pneumo without trying something first. So you should try a needle decompression or a chest tube. And kind of going again into our big picture framework, clearly this patient was really, really sick, had a kind of imminently life-threatening condition that we needed to treat. Like we already talked about a little bit, you can, if you have two options of needle decompression or chest tube, pick needle decompression. That's the quicker of the two options, but the more kind of long-term option of how you're going to management once they're admitted into the hospital would be a chest tube. So you do the needle decompression, and then after the patient is stabilized a little bit, you'll put in a chest tube because there's likely going to be reaccumulation of air in that area. And so you'll want to have a kind of bigger hole for that air to escape versus just the needle itself. So yeah, that's kind of the gist of any tension pneumo question you get. Those are kind of the big things you would see.
Awesome. All right, let's keep it going and we'll do another one. We now have a 64-year-old woman. So again, starting with the question, keeping with that theme, which of the following is the next best step in management? And so now we have a 64-year-old woman with hypertension and diabetes is brought to the emergency department via ambulance 45 minutes after the acute onset of numbness and paralysis of the left upper and lower extremities. So, again, taking inventory, taking a second, acute onset, this has kind of happened out of the blue. So she was fine and now she's not in the span of the last 45 minutes. So that's maybe gives us a little bit more urgency to what's happening right now. Denies headache or visual changes. Her blood pressure is 162 over 85, and she has absent strength and decreased sensation in the distal and proximal left upper and lower extremities. Her pupils are symmetric and reactive to light. Her serum chemistry is unremarkable. Hemoglobin A1C was 8.1% 1 month ago. Which of the following is the next best step in management? And so again, kind of like we've done with that framework for all of these questions, what do you guys, how is this immediately life-threatening? And if it is, what treatment do you want to do? If it's not, do you want to do any diagnostic tests, or do you still want to start the first line treatment from a clinical diagnosis? And so, what do you guys think? I see a lot of thoughts coming in for awesome. This is great, guys. So a lot of people are chiming in with great with stroke, and that's exactly where your brain should kind of be going in the premise of numbness and paralysis of the left upper and lower extremities, kind of acute onset is pretty concerning for a stroke. And so you have to think about, do we need to start treatment right now? Do we have a little bit more time to kind of clarify what's going on? And so in putting her into a framework, you worry, there is a sense of urgency to this because the neurologist often references this phrase, time is brain, and you want to be able to reperfuse as quickly as possible, but you need to do it in a safe manner. This isn't immediately life-threatening, like the patient will expire within seconds to minutes, but we do need to move quickly. So we have time for a diagnostic test. And the diagnostic test of choice in kind of working up a stroke is you want to get a head CT. And this is, a lot of people are chiming in precisely the reason why. The treatment of choice for a stroke is going to be, for an ischemic stroke, is going to be TPA. Going in and dissolving the clot that's causing the ischemia, but you certainly don't want to give TPA to someone with a hemorrhagic stroke. And so for that reason, you need to do a head CT to help differentiate. You need further diagnostic information. Is this an ischemic stroke? Is it a hemorrhagic stroke? And based on that, that'll guide your next steps in management. Some of these other choices, the main one is B, but for precisely the reasons we mentioned, you want to get more information before you do that. If it were a hemorrhagic stroke, you would consider controlling her blood pressure and looking into labetalol. In ischemic strokes, we actually do permissive hypertension, to help with brain perfusion. So again, we need more information to guide our next step in management. We don't, to guide our treatment, we need more information. So the next best step in management is obtaining that information with this head CT. She's not having a seizure that would make me think that she might need an anti-epileptic. And it seems to be more of a central nervous system problem. Nerve conduction studies they're laborious, they're expensive, they take a long time, and they won't answer the question that we're looking for. And then finally, this is another great diagnostic test to think about in certain scenarios, but you'd be looking for probably meningitis. And this isn't a very compelling vignette for meningitis. And so again, A is the correct answer here. So putting it back into this framework again, it's not immediately life-threatening, but it's scary. The diagnosis is not perfectly clear. We know it's a cerebrovascular accident, but we don't know if it's hemorrhagic or if it's ischemic. And so you need to get a head CT to exclude a hemorrhagic stroke before you get TPA. I hope that makes sense. If you guys, if there's any clarification that we can give at any point for any of these, just chime in the chat and we'll answer it in real time. But we'll move on to our last one.
All right, so this last one, again, is which of the following is the next best step in management is our question. So this is a 72-year-old woman with a medical history of hypertension, hyperlipidemia, diabetes, and recent COVID-19 infection who's coming to your outpatient primary care office complaining of a tight band type feeling around her chest with associated epigastric discomfort when she's walking. These symptoms have never occurred prior to the presentation now. Her vitals looks like she's afebrile, heart rate 72, blood pressure is 149/65, her SpO2 is 100% on room air, and her baseline EKG is significant for Q waves in leads 2, 3, and AVF with a left bundle branch block. So which of the following is the next best step in management for this patient? So big picture, before we move on to kind of looking at the answer choices, what do we think is going on with her? Again, your differential might be kind of broad for this one, but what's the kind of one thing that you really want to make sure is not going on, something that's a little more serious that she could have with these symptoms? Great. There's lots of people chiming in the chat. So big picture, if you have somebody coming in with kind of chest pain and epigastric pain, especially in a woman, we know that they tend to present a little more atypical for myocardial infarction. So as you all said, MI is kind of the big thing that you want to rule out in this case. And especially in her history, she's got hypertension, hyperlipidemia, diabetes. She definitely has risk factors for it. And then tell me about what we think about her EKG. What's kind of going on with her EKG? What does that kind of give us some hints about? Yes, perfect. So lots of people are kind of chiming in and saying that, given that she has these EKG changes, left bundle branch block is kind of non-specific. That could be because she has some left ventricular hypertrophy or something going on like that. But these Q waves in leads 2, 3, and AVF are showing us that she has a previous MI. That's pretty, pathognomonic for a prior MI in whatever leads they're in, is those Q waves. So she has a previous history of MI, even though, again, she's telling us that, she's never had these symptoms before, but we know that she's had an MI in the past. So with that information in mind, knowing that she has some abnormalities on her EKG and knowing that, she's had an MI in the past, what will we do next? So what do you think our answer is? So our options are, do we get a transthoracic echo? Do we do a diagnostic cath? Do we refer her to a cardiologist? Do we get myocardial scintigraphy? Do we do a stress echo, or do we get an exercise stress test? This one is a little tricky. I will say this is one of the harder of the options that are of the questions that we've had. Let's talk about some things that it's not. Let's kind of go through that, because I feel like that might be a little bit easier to go through. So do we think that she needs just like a regular echo? Probably not, right? Those are the things that we look for valvular abnormalities, if we're concerned about heart failure, if it's something kind of more longstanding and chronic. And this sounds like it's something, a little more acute that's happening. And it doesn't really sound like heart failure type symptoms. So probably not going to get just a regular echo in this case. A diagnostic cath, while sure, she might need that eventually, that's a little invasive, right? Like that's probably not going to be the first thing we skip to when this lady is otherwise, hemodynamically stable, her blood pressure is a little high, but she's otherwise stable. We're not going to, rush to the cath lab with her. I will say refer to cardiology. Is a great option in theory, and in real life, maybe you would refer her, if this is your family med clinic, maybe you will refer her to cardiology. However, on this exam, I will say referrals are hardly ever the right answer, because most of the questions that they're giving you, they want you, as whatever specialty you are going into, to be able to think about this, because these are a lot of, fairly common but also serious scenarios that you might get into, in the ED when you're on your rotation there, or things like that. So while she might get a referral as well, it's probably not the best option. And then we get down to the last three answer choices, which I think we've got a lot of people kind of between some of these options. So big picture in her case, is because she has these underlying changes in her EKG. While an exercise stress test might be great for someone who's never had an MI before or doesn't have any changes already on their EKG, to kind of see if there's ischemia that can be produced when she's exercising. In her case, it probably is going to get covered up if she's having little episodes of ischemia, from angina and things like that. We're not going to be able to see that because she has these underlying abnormalities. So big picture, the answer to this question is E. You would get a stress echo in this case. So that would allow us to stress her, AKA get her to exercise and kind of induce some of these symptoms and induce probably the intermittent ischemia that she is having. But then also see that physically happening on echocardiogram versus looking at it on an EKG. And really big picture, you just have to know that if anybody has underlying EKG changes, in those cases, if you're concerned about an MI or concerned about angina, you're not going to be able to see those changes with an exercise stress test like you would in other patients. So great discussion. There was some other questions in the chat about, could you do like a chemical stress test? So do, one of your medications that can induce these symptoms, and that would also work. So they couldn't give you stress echo, like exercise stress echo, or, a chemical stress test. Those are compatible. So they wouldn't be able to give you both of those as options. But yes, that would work to do kind of your chemical stress test as well. But you would just have to do it with echo, not with EKG. Perfect.
It's awesome. Y'all are brilliant.
Yes, you guys did great.
Cal, if you want to walk us through the framework.
Yeah. So big picture in this case, this was kind of a little one that's like on the fence. She's not like, she's hemodynamically stable, but she's not acute, in an acute situation that's life-threatening. But you kind of want to make sure that there's nothing more serious going on in the background fairly quickly. So this is not a patient you're just going to send home and observe. You want to order some tests and, make sure you're kind of working up what's going on. But in her case, it was really picking up, the kind of little nuances in which test is better for somebody who already has underlying EKG changes. And so, definitely want to make sure that we're thinking about that if you ever encounter this in another patient. But really, kind of your exercise stress test with an EKG versus an echo are kind of going to be your two go-tos depending on what their baseline EKG is.
Awesome. Well, you guys are, again, brilliant. Love the chiming in the chat. You guys across the board, we're getting these. And so hopefully this just helps you kind of put an organization on how to think through this. And so just to wrap up, again, give you guys a little bit of an idea of who we are here at Blueprint. We're really committed to helping you again through every step of this process. And just to highlight what the one-on-one tutoring includes, it's something that both myself and Callie do. It's really, working with students on an individual basis. And the beauty of it is you kind of have someone in your corner who's been through this process, knows how it works, has demonstrated success with it, and is able to kind of walk you through to see the same results. So creating a custom study schedule that is adaptive over time and kind of makes sense to when you're taking the exam, how quickly you want to progress your goal score. The nice thing about the one-on-one meetings is where we kind of dive into content and review, self-assessments and how your performance is. but it's also, we're here in between meetings too, and kind of helping just to have someone in your corner throughout the whole entire process. We are offering a few promotions. So if you are interested in pursuing this, and are motivated to have just a consult, even just a consult with our team tonight, a free phone consult at the number below, you can get 10% off on tutoring. That promo does end tonight though. And we also have a promotion that we're running on Gram Fighters, where you get 20% off a 6 to 12 month package. The promo code is Spring22. It's also in the chat as well. That also ends at tonight as well. So if you are interested, we'd encourage you to look into that. And so again, yeah, if you have any questions, anything further you'd like to learn about who Blueprint is, who Med School Tutor is, just, here's our email at the bottom, our phone number, just give us a call. And so with that, we'll kind of move on to the Q&A. So if you guys have any questions about, of course, any questions about any of the things that we discussed tonight that you'd like us to clarify, we're more than happy to. If you have even just broader questions about how to prepare for step 2, how to prepare for step 3, how to prepare for shelf exams, we're happy to kind of field those as well. So this is your guys' time, anything and anything we can address. Okay, here's a good question as it relates to shelf exams. Someone chimed in, how do we break down shelf studying when there are overlapping areas? And so I'm kind of interpreting, there is a lot of overlap between, for example, like internal medicine and family medicine, or maybe like neurology and psychiatry. Callie, do you want to take this one? And
yeah, I think, that is a great question, because specifically, I think when you're trying to do it in UWorld, that's probably where it gets the most tricky. Of course, there's other great resources that you can use in terms of, some textbooks and types of other things to study for those more kind of specific things. But specifically, I think for like family medicine, that's probably the best example of where there's lots of overlap. And I would say it kind of really depends on what your third year schedule looks like. I usually recommend that students do kind of UWorld as they go along throughout the year with their shelf exams. And so let's say you have internal medicine before you have your family medicine exam, it might be possible for you to get through all of the internal medicine questions during your internal medicine block, or it might not. So it might be worth it to, kind of revisit those questions or revisit specific topics within that section when you get to family medicine that, seems really relevant. I will say, family med, can combine internal medicine, OB, peds, psych. And a lot of the things that family med focuses on is a lot of the kind of like screening guidelines. So really emphasizing those things, like, when you get pap smears, when you get a high resolution CT and a smoker, or when you look for abdominal aortic aneurysms, things like that. And so really focusing on those aspects of all of the other kind of specialties that you might have already done UWorld for, I think is really kind of the best thing to kind of hone in on. But otherwise, and again, even like surgery has overlap with internal medicine too. So kind of, spending some time revisiting big topics. For example, like a lot of your infectious disease type things come up from internal medicine, also come up in the context of post-surgical issues. So yeah, just kind of finding those topics that really seem to have that overlap and just revisiting those, whether that be in a textbook, online med ed, if you're using 2Q banks, kind of doing some of those questions in either AMBOSS or UWorld can be really helpful.
And I will say, actually, I think the UWorld, it's changed from when I was a medical student, but I think they do let you go by shelf exam now. Or like by I think they have like a checkbox that you can put for like family medicine if you're trying to focus just on that shelf. We have one other question that came in, another good one. How would you go about step 2 studying and scheduling enough time for it? And you know, it's a good question, and it's a broad question, to be honest. It's the kind of 20,000 foot view of how to prepare for step 2 is, you know, the single most important resource that I think, especially as you get further and further into these board exams, is questions. I mean, so identifying a Q bank that you like and you feel comfortable with and you feel like you're learning from. I personally really liked UWorld, but you know, I think there are other good ones out there too, like Amboss, I think is really up and coming. There's a USMLE-RX Step 2 CK Q bank. There's a Kaplan Q bank, but you know, I personally focus mostly on the UWorld and try to get through. You know, I think in terms of scheduling enough time for it, again, thinking about what does your curriculum look like? Like, how much time do you have to commit, dedicated or otherwise? How many questions do you think you could get through each day? It's really just a numbers game. You know, if you want to get through X number of questions and you think that you can do so many per day, then do that math and figure out how many days that's going to equal and time the timing and when you'll take step 2 accordingly. Um, but that's yeah. And then of course, and I have to put in of course a plug for Roche Review is an incredible resource to prepare for a lot of the shelf exams. A lot of good content there, and you'll also be able to get a free trial if you're interested in looking into that. And so that's another great question. Well, maybe give just a couple more minutes, maybe a couple more seconds if anyone else wants to chime in.
I will just say real quick, unless there's any other questions, the only other thing I'll say about step 2 is you probably will be in your peak of all knowledge, like in terms of, you know, you just came off of an entire year of doing all these shelf exams. So you're probably going to be at your peak of knowledge towards the end of your 3rd year. And so so if you can schedule it, you know, again, it depends on your school schedule, but if you can give yourself a couple weeks of, you know, a more dedicated period to study, but if you got through a lot of UWorld or a lot of your preferred question bank throughout, you know, your 3rd year, and you feel like you remember a lot of the content, taking it sooner rather than later can be really helpful, just because, again, you're fresh in all that knowledge. And it's nice to get it done before you get into all of your, you know, sub-Is or acting internships, and, you know, getting a score back before you submit your residency applications can be really helpful, especially now that we're moving into the age of step 1 being pass-fail. So that's just another little tidbit about scheduling.
All right, guys. Well, awesome. Well, thank you so much for tuning in tonight. It's always a blast to be able to spend our evening with you. We hope this was helpful in terms of thinking through those. Hopefully, you've gone from dreading those next best step in management questions to looking forward to them. And you know, again, of course, if you're interested in learning more about who we are here at Blueprint and Med School Tutors, just feel free to send us an email or give us a call.